Good afternoon, everyone. We are going to start today's session, and as like discussed in yesterday's session, that we have to conduct something today just to mark the attendance of few people who took leave from their institute. So that's why we have just kept this small session on trustworthiness in qualitative studies. And I'll be showing you few of our work where we have initially tried to maintain some trustworthiness, but we could not follow every point of this trustworthiness. So, am I audible after
Yes,
speaking?
ma'am.
Oh, thank you. After speaking so much, I am asking. Okay. So, and this trustworthiness, I think one participant asked also in between, I think on day one session that, how to generalize the finding of your qualitative research, because we always talk about the internal validity and external validity or the generalization. So we'll see how we ensure all these components in case of a qualitative research. So trustworthiness matters in qualitative research like in any other research, because of course we learn from each other and we want our work to be of some utility to the policymaker and to the people who are in some other part of in this geographical in this global scenario. So let's see this with the two scenario. So we have just taken this example, only the doctor patient communication barriers. So if you see, this is scenario one. So a researcher conducts only three interviews. So the number of interview is very small, and he did this only from a same hospital, one urban hospital, and he did not record any like observation, reflections. He did not write the field notes or the participant responses in between, and there was no triangulation. We'll discuss what this triangulation is also. I mean, we discussed it on day one, but again today we'll discuss. And when the finding was being reported, they generalized this urban experience to the rural hospital also. So, what is your opinion of regarding the trustworthiness of this study, whether it is low or high?
Low.
Low. Very true. It is low. Now the same, so that it lacks the credibility and transferability. We will learn these terms. Transferability is generally, we don't talk about the term generalizability in case of a qualitative research. Instead, we talk transferability, because then the knowledge can be transferred or it can be applied to the similar setting. Coming to scenario two, if you see this, the researcher interviewed 30 doctors and he took both the facility, both the urban facility as well as the rural facility. He did the participant observation, he took the detailed field notes, he wrote his reflections, and he did this member checking also. And then he analyzed the data using more than one coder, and just to see the consistency and the dependability. And then he described the findings, very richly in a very thick, rich quotes. So, in your opinion, is this result is, I mean, this qualitative research is high or low? So, as Dr. Ravi and many other people are writing, it is high. Dr. Pukimala is also writing, it is high, and Dr. Arun also. So, this study is credible, dependable, and transferable. So, why does this trustworthiness mean in the qualitative research? It is very important because if you take care of these points, yes, Dr. Pravina, right. If you take care of these points, definitely the impact of your research is going to be high, because after all, through all this hard work, what do you want? You want the impact of your you are desirous of a high impact from your research. That's why you are doing a research. So it ensures that whatever the finding you are reporting, that is credible, that is dependable, and that is applicable. We'll see these points separately. What do I mean by credibility? What do I mean by dependability? And what do I mean by applicability to the real world context? And it generally there are four components of this trustworthiness. So the first is the credibility, and it is similar to the quantitative internal validity. So in the quantitative research, we talk about the internal validity, and this credibility is similar in the qualitative studies. Instead of internal validity, we say the term we use the term credibility. The second is the dependability. So dependability is similar to the reliability or repeatability in the quantitative research. So in quantitative research, we generally talk about the reliability or consistency. Like if you repeat the same experiment, you will get the result in between those two standard like confidence interval. Your result will lie between those two confidence interval. That's what we mean by the repeatability or the consistency or reliability. So this term is replaced by the term dependability in case of a qualitative research. So credibility is the internal validity and dependability is the reliability. Coming to the third measure of trustworthiness is the transferability. And like we discussed, the generalizability or the external generalizability, like the finding of your result can be used it as a policy making. If the study has been done in Africa, can that result is applicable to India? So that is known as the transferability. So generalizability of the study is this term is replaced by the term transferability in case of qualitative study. And then there's something known as the objectivity. So objectivity in case of a quantitative research, because objectivity is what generally you object how you ensure objectivity in quantitative research. So you try to remove biases. Biases means any measurement biases or biases in reporting or biases in let's say you know again the same thing. Measurement means any instrument error is there, or any there are two observer, and two observer are, let's say, observing the same thing. So we measure agreement, like whether there is an agreement or not. Remember, we measure like scale in scale development. Also, we have seen that we do this through ICC, intra-class correlation coefficient, or Cohen this or kappa agreement or modified kappa. So we do this objectivity. Objectivity is what, like the result should be very objective and it should be free from error, and that we achieve through removing the inter-observer bias, intra-observer biases. So if you see this conformability, this is entirely related to the research participants. So we will have to do all the work on the context. We take the data from the research participant, and this conformability, this is entirely the researcher reflexivity, which we were talking, keeping his or her own biases aside, and the phenomena of bracketing which we have learned. So this will help in maintaining the objectivity or conformability, and in between there are other techniques also which helps to maintain or which helps to report a high trustworthiness from your qualitative research. So how to measure this trustworthiness? Uh, just a second. Yes, so how to ensure trustworthiness? So this trustworthiness, the first thing is like there are many methods. So first, very important method is to follow the triangulation. What is a triangulation? We'll see. The second is the member checking. The third procedure is to write a very thick description of the quote. Means you should give only those quotes which are very thick and which are describing the phenomena of your interest or phenomena of your research question. And then the next one is the audit trail. So these four are very, you can say, four pillars of ensuring your trustworthiness. So coming to this triangulation, triangulation is, as the term suggests, three triangle. Okay. So it is basically verifying your data, your analysis, and your participants, at least three. So either you can do the triangulation in methods, like you have seen people are using more than one method, research method, or you can use more than one type of participants. Like in case of a filariasis project, we have taken the healthcare worker, we have taken the uh, field grassroots level worker, patients, and the relatives. So that can be one thing. There can be triangulation in the data collection method. Like you can do focus group discussion, you can do in-depth interview, you can also observe if possible, or you can also take the some secondary data. So if you are using more than one data collection technique, then it can be triangulation. And then if you are using more than one analytical technique or framework, that is again a triangulation. So member checking is you share the your transcript to the participant and they confirm whether whatever they have said is it the same thing, or they said something else and we interpreted something else. Then third one is the thick description. So we provide a very detailed description of participant, setting, and also the background, and also thick description is about the quote. And then you also document the decision. So we will see what is this audit trail. So basically, whenever you start doing a research, you write everything. When did you plan for your protocol submission? What happened after that? When you start your data collection? When did you do the pilot testing and all? That we'll see what is this audit trail. So coming to this first one, that is the validity, internal validity or of your findings. So this internal validity is also known as the credibility. That means how well, and I said in the beginning that it is related to the participants' experiences or participant data. So how well the researcher represents the participant experience. So again, this example of communication barrier. So a study explores the chronic disease patient experience of this telemedicine to ensure validity. What the researcher did, he used triangulation. So he has taken interview, he took the patient feedback, and he has done the doctor's observation also in the OPD while they were doing the communication. And he has done the member checking also by asking patients to review transcript for accuracy. And he has provided the thick description of the patient healthcare context to enhance the interpretation. So the outcome is like he has captured this participants' voices or participants' words very correctly. Whatever they intended to say, he has captured it in a real-time basis, and that's why we can say that findings are credible or there is an internal validity. So, like we say in validity in quantitative research, how do we maintain validity in quantitative research? So, we always are very stringent about our selection criteria, about our inclusion and exclusion criteria. We take care of removing any selection biases by doing randomization if it is a randomized control trial, or by doing some probability type of sampling so that we can have this generalizability. And again, we do the stratification and we do all sort of reduction, take measure to reduce the error, and then we do the multivariate analysis also. So these are done to ensure the internal validity. Now in qualitative research, we achieve this by these methods. So there's a triangulation, member checking, then there's something known as the peer debriefing. Then there's another method which is the prolonged engagement with the participants. Then the way you conduct your interview and the reflexivity of the researcher, and then negative case analysis. So we'll see each of these concepts one by one. So coming to triangulation, as we have seen, triangulation is like a triangle. So basically, you try to uh, take the sources more than one sources. So you use multiple sources of data collection or multiple sources of data analysis to enhance the credibility. And basically, what does it help? So because if you are taking the multiple sources of data collection, definitely different perspective will be collected, and it will lead to a more comprehensive understanding. And if you are taking more than one participants, also stakeholder, again you are having multiple perspective. Like in case of a doctor-patient barrier, on day one, one participant was saying like, why are we taking only the interview of doctor? Why not patients? Then we said, yes, we cannot interview only doctors. You have to interview other stakeholders also. This was just for the purpose of, you know, demonstration. Here in the workshop. We have only taken the interview of doctors, which you people did between each other. So basically, you want to have multiple perspective, because we have seen on day one about the multiple reality, and qualitative researcher believes in multiple reality. He will not go in the field with a preconceived notion that he is the sufferer and the healthcare worker, because most of the time what happens that generally there is a blame game for doctors, that doctors they don't have time, or they are not into communication for any research question. So generally, we try to blame the people who are at a higher level, that they don't take care of the people who are there in the periphery, or who are down the line. But again, if you take their perspective, like I was telling you regarding the iron folic acid tablet also, that when we inquired regarding IFA, because in spite of the availability, the intake of iron in Bihar is only 11 or 12%. Like only 12% of women take iron folic acid tablet in their pregnancy for at least 100 days. So when like we are in the process of doing that study, but if you want to know their perception, so they again said a lot of things like medicines which are there that is of low quality, and they consider many other quotes came up. So you can see, like, you cannot say like there's a non-availability of medicines in the government sector, or generally people blame that dawa milti nahi hai, no medicine is not available. So for that you want to align the multiple perspective of people, because it is helpful to know, to make a overall conclusion, or to make a overarching theme through which you can explain your finding. So this triangulation is important. So the on day one also we have seen this slide, that it can be through three ways. So this is a triangle. So the triangulation can be done at the level of multiple sources of participant. So any qualitative research, you try to have triangulation at the level of participant, and that can be done very easily. You can identify stakeholders and you can collect data from them. The second can be from the level of data collection. So at least you can have some secondary data, or you can have some observation, some field notes, and then you can have this either focus group or IDI, or you can have both. Like in one group, you can do focus group discussion with one sort of participants, and with the rest of the participants, you can do a stakeholders, you can do this thing, in-depth interview. So that can be one way of triangulation, and triangulation can be done at the level of this analysis also. Like we do content analysis. So content analysis is like showing the frequency, what was the percentage of codes which was appearing. So more, and then we do the grounded theory also, or you do the simple thematic analysis. So if you are using more than one type of analysis methods also, then also you are doing a process of triangulation. So we try to follow at least one of these methods to ensure that yes, there is a triangulation. You have tried to achieve triangulation. Many times it is not possible that you do all the three type of triangulation is not possible all the time. But even if you have tried for one, at least identification of key stakeholders you can do, and the second, analysis you can do. Data collection, maybe many times we only go by the in-depth interview, But again, at least try to have triangulation in your research. If not, you yourself accept your limitation. That helps in understanding that that should have been done. But yes, all the I mean all the biases, it's not possible to remove for everyone, but at least acknowledging your biases is also a very it's a very good habit whenever you write your manuscript. Coming to the second thing, which is the member checking. So what is a member checking? Basically, we have discussed this concept previously also. So this member checking is also known as the participant validation or respondent validation. So it is again one way of enhancing the internal validity or the credibility or trustworthiness of your finding. And this member checking, generally, most of the time we do this member checking when we are paraphrasing the participants' sentences. So there are ways of doing it. You can return the transcript to the people and you can ask them to read and then confirm that finding, or you can share after the thematic analysis, you can share the whole manuscript or themes also to the participant to confirm the accuracy. But if you see in India, especially in Bihar, seeing the literacy status, uh, we have written also in one of the manuscript that member checking was not possible. The only member checking option which we did, it was while taking the interview. So why to do this member checking? Because this member checking, this ensures the trustworthiness and it ensures the validity. And again, like I said, that this validity is all about participants' words, whether we have understood them correctly or not. So whether we are reflecting their experiences and their words. So basically, when you give any transcript to the person who has said so, if he reads that, then and he says that yes, I have said so, then it reduces the researcher bias. So we did member checking for RSV study. RSV, like that respiratory syncytial virus where we were talking. So we returned the transcript to the higher officials. Like I think I only returned it to state immunization officer, whatever he has said, just to check. So then he agreed, and then we have like finally analyzed that. But generally, member checking is not very much possible at the people who are like at the level of beneficiary, because it is difficult, and we have not tried. Frankly speaking, I should not say that it is difficult because we have not tried it. But again, we are planning that with the next research, I mean, whenever we'll conduct the next research, we will try to take their phone number because they don't have their email ID. Then you will have to call them again or send the transcript to the WhatsApp method. We can see, but we have not tried for the beneficiary. So it is said generally all these things are done in the Western this thing research. Whenever they do like USA, Europe, they generally do this member checking. So there are two types of member checking. So there's a real time member checking, and this generally we do. Whenever they are saying something during the interview, generally we paraphrase it like yes, and we keep on summarizing whatever they are saying. And if they like nod yes, you are right, then generally we say see that yes, member checking we are performing. But this delayed member checking, that means returning the transcript, because this will be done afterwards when you are ready with your transcript, then only. So for that you need to have either their email ID or you will have to visit to their houses, because it's not certain that they will come back to you within that time frame, the time frame of your study. So it is done, this delayed member checking is done after the initial analysis, and sharing transcript summaries and themes for participants review. But there are some potential challenges also. Participants may change their opinion over time. Like maybe like 2 weeks before they said yes, and after 2 weeks when you send this transcript to them, they may change their few of the answers. But that you have to accept. And then sometimes it is time consuming. And again, I said that it is a resource intensive. You have to send the social worker to the house of the people, especially in our context, it is definitely a resource intensive. But for if you are doing something for medical education, you're doing something using the PG students or using the UG students, then you can do the member checking. We tried doing this member checking with the that HIV stigma study which we conducted with few of the private practitioners, because they asked for it, basically that we want to see whatever we have said. So that's why we sent these few transcripts to transcripts to few of the private practitioners. So now there's another way of ensuring this credibility, that is the prolonged engagement. Prolonged engagement is not possible all the time with us if my data, the type of research, if I'm not doing an ethnography or I'm not doing something where I need a prolonged engagement, then that can be one of the limitations. So that is not applicable for all type of research methods. If you are doing a qualitative descriptive, then prolonged engagement probably. If your research question is something where you don't need prolonged engagement, then this is not applicable. So basically, as a term, you see it says that you have to spend extra time. It is basically the observing, like you have seen the ICU study where the ringing the bell, the ethnography, where the person was saying the frequency of bell between the private and the double room shared room. So in that case, you can use this participant observation, or that's the most common method of doing this prolonged exposure, and it allows generally the researcher to go further in the investigation. So if your research question is something where you need to explore some deeper insight, or it cannot be done through the qualitative descriptive, you should be more exploratory. And if the research question demands the observation, then this prolonged engagement definitely helps. Like ICU, if you want to know the behavior of ICU, the people, how they are behaving or how they are reacting towards the grief, because we have found this. I don't know whether you have stayed any time in ICU or not, but few of my relatives during COVID and afterwards also, they were staying in COVID, this ICU, and every day like 1 or 2 person were dying. So they were so apprehensive that it now next is my turn. So just observing, sitting them there and observing the people talking with each other, because in COVID they were not very serious, means they were serious, but only in terms of low saturation, but they were talking nicely. So they were chatting with each other, and like they were sharing to us like it might be my turn tomorrow, something. So that fear, and that so much of fear was existing. So if somebody wanted to do that ethnography, how the people, this phenomena, people living in ICU, then you have to remain there for a prolonged period of time. So this is the prolonged engagement, and the one of the data collection method is the participant observation. So participant observation is like in this picture you can see, you have to be with participant. And this is a non-participant observation where you are standing outside this. So that's a non-participant observation. So how you have to prepare for a participant observation. So the way we have discussed, you have to take the approval and you should get the idea about the site. So if you are doing it in your own hospital setup, then you have a full idea about the site, and you have to mention the activities also. Because remember, we have discussed that within case sampling, what activities, what processes, what events you have to observe. So that observation, definitely it will come if you clearly mention and identify those activities. So those activity you have to identify. And if you do not belong to that, like if I'm community medicine person and I just want to do anything in the red area or in the emergency triaging, so there I'll have to go and see beforehand where will I sit and how I will be observing. So you need to visit the site beforehand if possible. And then how should I behave during the participant observation? So in this case, I'll be also acting like them. So I'll be helping out in few of the work also. But my role will not be to disturb any natural flow of the activity. So I will not be like disturbing them or demanding so that they'll have to take care. So again, you should behave the way the people around you are behaving. That's one way of a good way of doing a participant observation. And then you need to document. You need to write your reflections, whatever you see, and you need to also write your distinguishing point, like, because you start something with your assumptions and with your this thing interpretation. So you should mention again whatever you have assumed, how it is different, or whether it is in line with the way you thought about this participant observation. And in that context, you write about analytical memo. I think we'll discuss analytical memo on Sunday. What is analytical memo? Basically, analytical memo is whatever is coming to your mind. So it is just writing your own mind. And we also say that you should not be like delaying this activity. You should not be, very much sure that you will remember it. So never trust your mind and never trust your memory. So the moment something is coming to your mind, please try documenting it some way. What I do or what we did, like we used to record our own because there is a recorder in the phone. It is not always possible because you don't have a paper and pen all the time. And these days, but we are having our mobile phone. So using that voice recorder, what I did as this analytical memo, I was recording my own voice, which I have just made transcription of that, and that helped me to write the result section. I'll show you. So that is regarding the analytical memo. This analytical memo is important at the time of analysis also. It is not only at the time of observation, any part of qualitative research. If this analytical memo means whatever is coming to your mind, you try to document it. So this we are talking in case of a participant observation. What we practiced, that was during the time of analysis. We were writing a lot of analytical memos when we are seeing some code, because see, I'll show with the filariasis, because in filariasis, the patient was like very, not able to walk. So in my family also, like when my father was there, he was also not able to walk because of the severe scoliosis. So when the lady was saying the same thing, like I'm not able to walk, I cannot go to the other room, to the washroom, and the caregiver was also saying that there's a heavy responsibility to me. So I was like, it was kind of resonating, and it was kind of echoing the same thing. So I wrote my reflection also, because because we have also seen this situation. So that's how, but again, you have to keep your, like, bracketing, which I talked. You have to keep your thought process aside. So there is a difference between the two. uh, Bracketing means whenever you are asking something or you are interpreting something, you put your own interpretation, but that interpretation should not be biased by the your own experiences. So there is a difference. But bracketing means you will not deliberately try to hide some voices where you are not convinced. That is like your, by researcher biases. But if you are echoing something, and if you have undergone through same phenomena which the participant is saying, then definitely that thing which is going to your mind and you are writing it, that is known as the analytical memo. So there's a difference between the two, between the analytical memo and between the bracketing. So bracketing means, like, if you don't bracket your thought process, that means you are biased. Deliberately, you are trying to show something clearly, and you are trying to hide quotes where you are not convinced. That is your biases, or not maintaining reflexivity. So this was so the then how to differentiate between the ethnography and participant observations. So basically, this participant observation plus in ethnography, we have learned the ethnography, that basically the researcher is living with the people, and he is immersed in the setting for an extended period. Extended period is again relative. If you are living in ICU for 10 days or for 1 week, that is again one period. So depending on your research question, and then you make regular observation of the behavior of the members, and then listen and engage in the conversation, and you interview also few of the members. What we have seen in the study of that ringing bell, dancing bell, and then you collect other documents also. So that's why ethnography is basically the one method of data collection is the participant observation. Plus, there are other method of data collection also, like you can check records or you can do the secondary, you can take the secondary data and you can interview few people also. Now, there's another way of achieving this credibility is the peer debriefing. So what is peer debriefing? So like we talked about this shop talk. Remember that whenever you are doing this qualitative research, you should keep on talking to someone because the articulation of your own mental abstractness will help you in getting new idea, or someone else will also suggest something. So that was the shop talk. This peer debriefing is like you can debrief one of your peer members because again, then if you are narrating something, who has the idea of this particular research, then you can do this. But again, I said that generally the team members, we all are involved and we don't discuss our project and nobody is interested also seeing our situation. So generally, we have never done this peer debriefing. We generally do the with our research team we talk because we are a part of that team, but generally, I have not practiced this peer debriefing. But again, that is one way of doing the research. I mean, not the research, doing one way of ensuring the trustworthiness. Now, then another is the review, this interview technique and researcher reflexivity. So, researcher credential is also important, and that you have to write in your manuscript the team reflexivity and the researcher credentials. That what is your degree, what is your training, are you trained in qualitative methods or not? Or if you are trained, what about your team? How they have been trained in qualitative research methods? And then you have to write your personal informations also, like your gender especially, because in one of the research the basic all the people, the respondents were female. So in your team or in your, there should be some female also. So regarding your occupation, gender, experience or training, that is also important. Again, selection of the participant which you are selecting, and we also say that you should have a maximum variation sampling. That's what we discussed. Maximum variation means you should try, because homogeneous sampling you will achieve trans saturation very easily. So heterogeneous means you try seeing the outliers also, and for that you can talk to the person who are there. So through them, like snowball sampling, you can, which we call it as a theoretical sampling. So through one person, you can ask about other people and then you can go to them and you can inquire. Like for Swasthya Mitra activity, I'll show you. For the beneficiaries, we did that. We have inquired from, like we took the interview of one beneficiary and then we said that who are the other, like maybe because if I'm asking from one person, she's saying all good. Then I may have to ask about the person who was having a very bad experience about the hospital visit. So for that you should be taking help of someone who will ensure this maximum variation sampling. And then you should write the thick description of the setting and the thick description of the participants also. That is also very important. And interview guide, we have learned the importance of interview guide. So if there are more than one data collection team, so if you don't have a interview guide, then the data which you will have, that will not be consistent. Someone is asking some other question, someone is asking some other question. So in that case, if you have some framework, not the theoretical, but questionnaire should be like validated, pre-validated and pre-tested, and then you should give to them, and please train them well, because they are very young people, and you train them well, and then you like send them for few interviews which will be like a pilot interview, which we did many times. Like we trained our residents, we send them and to the field, and we have like sat with them and we checked their transcript and we have given our feedback, like this you have asked as a open ended, this you have asked as a close ended, so what you could have explored. So for a, if like your involvement is definitely necessary, because you cannot go and do all the data collection, but sitting with your team, giving them the feedback, checking their transcript before all the study gets over. Because if you are waiting for all the transcripts or all the interview to be over, then you cannot give the feedback. So it's better that after like one or two interview, you make the transcript, or you ask them to make the transcript, sit with them, give them the feedback, and then ask them to go and take another. That way, by the end of your whole study period. Otherwise, generally, what we do, I mean, our PGs also, they come to us towards the end when they have done everything. So then you don't have any scope of improvement. So what we also learn from our mistakes, and from now onwards, we have started practicing this. Like, we ask them to hold, conduct only one or two interview, then we sit with them, give them the feedback, and then we ask them to collect more. It might take some time, but again, the quality of the data which you have. Otherwise, description you will never get. This one, now I am telling you, they are they are in hurry. So this thick description you will never find, because generally our beneficiaries, especially in Bihar, and if they are women, because women, they talk very less here. They will always say, like, please talk to my. If I'm asking something from them, she'll say, I don't know anything. Please ask my husband or ask my mother-in-law. Then we'll say, no, I want to know your perception. No, 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 I don't know anything. Please ask my husband. So that everything, there's so much of I mean, empowerment is so less that they can't even say about their opinion, or about their perception. So that's why training, it is a time taking process, and you should train your residents, or if it is a funded study, then whosoever you have recruited, maybe a social worker. Generally we recruit social worker. So yes, you have to train them. And this is negative case analysis, is again like an outlier which we have seen. Outlier means, like, most of the participants are saying good. Like in case of a Swasth Mitra, that happened with us, like doctors, when we went to doctors, the health manager was very, no, okay, that yes, it is a very good initiative. But we went to one of the residents, and then he said that I don't have any idea about what is this Swasth Mitra. I have never heard, they don't come to. So he was all negative regarding this initiative. Uh, so Swasth Mitra is like a navigator, patient navigator. And this thing, let me, before that, I'll show that article so that you should have some mental picture what I'm talking. So this was the study. Exploring the role of Jivika Swasth Mitra Help Desk in improving healthcare access, a qualitative study in tertiary healthcare facility in Bihar. So this Jivika is a self-help group in Bihar. So what this was a funded study. So they took an initiative that to promote their livelihood, they have created a help desk in all the hospitals of Bihar, in all 38 districts, to act like a navigator, patient navigator. Because you know that whenever a person comes to a tertiary care hospital or maybe a district hospital, he gets lost. Where to get the registration, where to go for OPD, where to get for the pharmacy, where to get the investigation, blood, etc. So, and then whole time gets lost in that, and that person, he or she doesn't want to come to the government hospital. So just to increase the uh, footfall of the patients, and to increase their belief in health system, government health system, they have created this help desk. So we were exploring, we did what is the perception of people, the beneficiary and the doctors and the managers, regarding this help desk, and from the Swasth Mitra also. So here we met one doctor, and like one the superintendent was very good, like yes, yes, they are very good, because most of the time when you go, and if you are senior and they know that you have come from AIMS, then they will talk all good. They will not say, many times they don't say that social desirability which you people were talking. But if you select someone who are very unknown to you, uh, just we were crossing, and there was one resident who was very young. Generally, they, I think he was a PG in gynecology, and we asked from him, we just for the interview, and then he said all negative, like about the people, they don't wear dress and they don't help, or I don't know, when they are there, they don't stay at night. So that is like example of this negative case analysis. Because if you are taking all good, then you might, your findings will be shifted towards all positive. So if something is all the time coming positive, then this should flag, it should be there as a red flag in your mind that everything cannot be good. So you should try seeing participants who are like who is very critical to your initiative or very critical to a particular phenomena which you are studying. So it is, and through that you can constantly compare your finding and you can present that finding also. So coming to the second part, which is this was regarding the validity. Now next is your reliability. So reliability is again like it is, we say like it is the repeatability. So it is ensuring consistency in research finding, and this consistency is again across different setting. So for that, or the time period also. So it may be a different time point if I did something 3 years back, and if somebody is needing that particular finding 5 years afterwards, then is that finding the same repeatable or not? So this dependability we can see with this example. So the one research team studies this doctor-patient communication in hospital, and they ensure reliability by using the same structured interview guide. So they for that, this reliability is like again taking care that there should not be error in collecting the information. So they have used the same structured guide for multiple data collection team, and they have used more than one person to code the data. This is very important at this stage whenever you analyze, because semi structured interview that is there. But when you are coding, many times what happens that you give this responsibility to someone and you don't do it on your own. But you should, and on your own means I want to say like one person only does the coding and thinks that he's doing the right, but it should be at least two people doing it independently, and then you should discuss your code book. So like this study also, if you see this Swast Mitra here, me and Dr. Shamshad, both of us were doing the coding separately, and then we discussed the code book. And then we, of course, we have like reached to some consensus. So if you see here also in material and method, we have mentioned about the research team and reflexivity. And here you have to tell them about the team also. So we were having four resident, three females and one male. We have to mention that because I told you that gender is also important. All holding MD degrees in community medicine, and they were proficient in and regional dialect, and two were from the Bihar locals from the study side. So this they worked in pair. We write also like how they have taken the data. So we made two people, two teams, and we ensured that one female should be there in each team. So they went there, and then if you see, we need to take this call. Yes, Dr. Anand. हाँ मैं सेशन ले रही हूँ, लेकिन ब्रेकआउट रूम की जरूरत नहीं है आज. मैं तुम्हें करती हूँ. So you can see the study, this participants recruitment purposefully we have collected, and here you can see we have mentioned this like the analysis involved a systematic and iterative approach. The first cycle coding methods, which we have learned yesterday, are attribute coding, descriptive, in vivo, emotion, and process. We have used these many coding, and we have only used first cycle coding because we did not. Again, I said like many times, the funding agency were also they were in hurry to receive. They say that we need the report because they need to submit it to their Bihar government and to the principal secretary. So that's why we stopped at the first cycle coding. And then the two investigator independently, like we independently coded the data, and then we checked about any discrepancy. We have checked with this consensus and discussion. So in this case, what is one more thing which the Saldana says that if you can involve more than two people also, and then three people are coding and one person should be code editor. So this probably we are planning it for our next project, that maybe we can ask our two or three resident to code, and me and probably two can be a code editor. So you will only analyze whatever they are saying and you will edit the code finally. So that can also be one way. Either two people can do independently and then share their code book, or three separate person are doing and two people are like acting as a code editor. You can also do that. And then here you can see triangulation. If you see triangulation of data sources, we have used Swasthya Mitra, healthcare professionals, beneficiaries to enhance the credibility and reliability. And we have written like while participant checking could not be performed due to logistical challenges, reflexivity and team consensus were maintained throughout the analysis process to minimize the researcher bias and ensure a robust and faithful representation. And here also, like we have, because I said that many times, this if you see, we have given the attribute coding, like these were the beneficiary, the gender and the age. And we have also given this as in the form of a theme, how many themes and how many categories. This is one way of presenting the data. And again, if you come down, if you see the description, so the description, if this description I was talking about, this should be very thick. You can see it is not very thick. At times it is thick. Like I'll show you few places. Yes, if you see this was a thick description. Like certainly there has been difference. For instance, where there is an accident case, it can cause considerable trouble going outside to other medical facility would cost approximately 50 to 60,000. Here, that means government. So this here means this whatever I have put it in bracket. This is by my own interpretation. Means here by here she was meaning like government hospital. Your work will be done only in 5,000 rupees. Therefore, we explained to them, brother, you are poor, you might have to wait a bit, but we will get your work done here. This is the wordings of a Swasthya Mitra. And then, however, you still wish to leave or to know about other options, that is your choice. So this was a thick description. So if you can just see, if you go through few qualitative research and see the description, then you will come to know, and it will improve your art of interviewing skills also. Yes, many people are very good at taking interview, but those of you who are beginners or maybe who want to improve, you can use that. Again, I'll show you one. This was one study which we have shared. This absent organs, present selves, exploring embodiment and gender identity in young Norwegian women accounts of hysterectomy. This article is a very good, very nice article. And if you see, I was going through it, and if you see the description, see how big they have written this paragraph. We have been told that next time if all tests were fine. I mean, I'm not going to read this, you can read this, but very thick description. Again, if you come down, see, they have spoken so much. Here also, in the first period after surgery, I thought, so it should not be like one or two lines, or then it will be very thin description. So descriptions should be very thick. Again, if you see, this was one of the article which we did on palliative care, like lived experience. This was it was a phenomenology actually, but we did not mention it. But it was the lived experience of palliative care among people living with HIV/AIDS, because they were the advanced HIV/AIDS people. And if you see here, we have written the limitations also. So this was like here the strength is like we triangulated data between the respondents. So here I said that all the time all triangulation is not possible, but here the triangulation was done between the people living with HIV/AIDS, caregiver of the hospitalized patients, and relatives of the deceased patients, and the key informant interview from the community-based organizations. Here we have interviewed those transgender, which I was mentioning yesterday. So triangulation, we had tried to achieve triangulation in the participant, the type of participant. And then again, here also we have mentioned that we strove for theoretical saturation in the study sample as a whole, but did not achieve saturation. So here it was a purposive, and since we did not achieve saturation, we have mentioned that we have not achieved saturation. So that you can write whatever is the true situation, you can accept. So that's what accepting your own limitations. And that's a good way, because then the reviewer also knows that, yes, now coming to triangulation, this is a file area study, if you see, which we were discussing yesterday. Whenever I tell her to wear slippers, she turns a deaf head. She turns a deaf ear and she never listens. If you see this, here we have used the triangulation in the responses also. Here you can see this is a little thick description, but again, if this is again not very thick, if you come down, yes, this is like a triangulation. So this theme, low adherence, we have made a theme category of low adherence towards MDA, which is the Mass Drug Administration. So here you can say that there was a lack of trust in the government supply of free MDA drugs. Some said straight away that they did not consume the medicine given to them biannually. This problem have been shown by from the perspective of a patient, relative, and healthcare worker. So all three said the same thing. So patient is saying, I was taking another medication. How could I take another? When they gave medicine, I thought I will take it, but same night I got fever and chills. Then second person caregiver is saying he doesn't listen. He says it doesn't work. Taking only those medicines from private work. If it is for deworming, then he takes it from the government supply. And then the third healthcare worker is she's saying that when I meet those people, I ask them whether they took the medicine or not. Few reply yes, while the others say no. Most people don't take it because it is a supervised dose. Most people don't take it in front of me, and I don't know what they did with the drug. So this is like a triangulation in responses also from the three participants. So you can make so you know there is a way of identifying the theme also. So if something is being said by all the stakeholders, so try identifying that, and that is like you can take that as one of your strongest theme, or maybe one of, because that is coming from all the end. So probably that's why low adherence, we thought that this is one of very important theme from our perspective in this study. So this is regarding your this credibility. So again, you will see that we have not mentioned this credibility or trustworthiness everywhere. You try to maintain it and you try to report it. If even if you have reported, you start reporting it. Maybe slowly you will do everything and then you will report everything. But try, taking 1 or 2 points at a time. You cannot do everything. So again, this was like we have seen this intercoder reliability. So you can do that either by a code editing method, like one can be a code editor or two people can be code editor and rest of the team can be doing the coding. And yes, we always do this, conducting pilot interviews. Pilot interviews, this is very important. You ask all your residents to do at least 2 or 3 pilot interview. If you yourself are doing, then also you conduct few interviews initially just to, don't include them if they are not good. Just to, it's a self improvement process, and you can analyze your own way of, you can improve upon yourself. So outcome is like findings are replicable and consistent, reducing researcher bias in the data interpretation. Now coming to the generalizability or the transferability. So it is like whether your research is applicable to the other context or not. So to the extent you can use the findings of some other research, or it can be applied in some other area. So the same example, the communication challenges. So the study on nurse-patient communication barrier, it is conducted in an urban tertiary care hospital. To enhance transferability, the researcher provided the detailed description of the participants and the setting. So demographics, like you see, I was talking, like you have to give the demographic detail of, that's what those attribute coding was. And you have to give a table also where all participants, their age, their occupation, and probably maybe a few more you can take, like maybe if you want to take socioeconomic status. So all these socio-demographic variables, because that variable is a very important variable, and to see the transferability, one will need this. If you are doing something in hospital, the hospital setting is also needed, where it is a tertiary or it is a primary, what type of patients come, whether it is a local patients or like names, patient comes across bordering districts also. So you have to mention if you are doing it in names. And then patient provider interactions also you have to mention, like whether you have done it in OPD. OPD is like, whether it is in one room, everyone is standing, or so some context that you have to describe. That's what those field notes are. Whenever we ask you to take field notes, how it will help, because those field notes is about describing what you felt at that time. People were coming, going, or like a few were interrupting, so that gives something of contextual information also. So that is important. Those field notes are very helpful in writing this detailed description. And as we have discussed earlier also regarding the purposeful sampling of diverse patient group, like uh, you know depending on a research question. So again, the researcher can determine whether these findings are applicable to different hospital or any other research which you are doing. We are just giving the example of this doctor patient communication. So how this reliability, validity, and generalizability this works together. So probably if the through this maintaining of the research team reflexivity, conduction of the in-depth interview, or doing the uh, taking care of the this thing, what you say, the triangulation of the data, the member checking, and then if possible peer briefing, peer debriefing. So if you take care of these things, and then definitely these work together. So reliability, researcher ensures that all interviews are followed a structured guide. There should not be any change. Validity, we triangulate our finding, and generalizability is the detailed description of the setting. So again, reflexivity. So this we'll do in the curricula checklist also when we'll do the how to report your finding. But this reflexivity is acknowledging researcher bias. So this is one situation. Dr. Sharma, I think someone can read this. I'm speaking all the time.
Dr. Sharma, a public health researcher, is conducting a qualitative study on rural healthcare access. Having worked in urban hospitals for most of her career, she believes that rural patients do not prioritize healthcare visits as much as urban patients do.
Thank you. So as she begins interviewing rural residents, she asks. So this question, if she asks, like, and you will see that we also ask such questions, especially in. I'll give you one example. Here the question is, why do people in your village avoid visiting doctors until their condition worsens? So you will see, like we always say this to patient. If the patient comes very late, in very late stage, you will see doctors often, shouting, "Why have you come at this stage?" So then what will he answer? So he is just clueless because there is so much of story behind it that he cannot say in one word or one sentence. So this is a biased question. So what she should have asked, like she should have asked, because she should not assume that they avoid visiting doctors, or they avoid until the condition worsens. So basically, after reviewing her old, because if she is practicing this bracketing, then she realizes that her urban background is influencing the approach. So she rephrased her question, and she asked, like, again, it is like, can you tell me? So Dr. Ravi, many times you can ask like a question starting from, can you tell me about, or please tell me about your experiences with healthcare services in your village. So that question, it is like a neutral, you have to maintain a neutral tone whenever you are asking questions also. Like I was sharing my experience regarding that HIV, so I was very judgmental at that time in that first few interviews. But afterwards, I realized, and maybe many times your other team member will also make you realize that you should keep your emotions aside, so that you can practice. It comes with experience and with practice, this acknowledging our own biases. So we have observed from this example that there was a preconceived notion regarding this urban people, and that's why the question framing, it indirectly it comes to your in the language, because you will see again in many committees also we review thesis and we review the research question and objectives. So many times the residents, they write that uh, if we say what are the perceived barriers, so barrier means since beginning you have acknowledged that yes, there will be barrier. So factors to remove those barriers. So we always ask them, like, have you studied barrier? If you don't know that there are barriers, how will you remove? So that's how we should not go by assumption. And this reflexivity helps us to correct those biases, and we will have a better data quality. So again, this reflexivity, I said that it will not go in a day. It takes time and it is a continuous process. And again, like you have to work upon yourself to keep your emotions and biases aside. And definitely, if you see the result and if you see that there was a description of some negative and outlier case also, then you can understand that yes. So by practicing that deviant case sampling or maximum variation sampling or negative case sampling, you can rest assured that yes, that a researcher has tried to keep the her or his reflexivity. Now there is something known as the audit in research. So what is this audit? So basically you maintain a research audit, which is very although frankly speaking, we teach this academically, but we have not practiced this audit. In fact, recently only we came to know that we should have maintained that. But frankly, I did not. We have not maintained this audit for any of our research, and neither seen someone maintaining it. But it is a good idea, and probably we are thinking that for our next research we will maintain this audit. So it is like you maintain all your activities in like diary we write the, and this audit we have maintained this for meta analysis. So we did one meta analysis and we conducted the workshop also for meta analysis because there was a huge article and it was like we were doing it in a very taking big breaks. So we maintained this audit in meta analysis, but in qualitative we did not maintain. So this is like you write all the log, whatever, like the way you are maintain your diary. Like today you have to do this work, or you did this. The next day, what any decision was changed, and then you did. I'll show you one template for audit also. So here you write your with the whatever field notes you have brought from the field, or you could not take the field notes, or you like write that if you have taken any reports from someone, you also write that. So this is basically this will again it is for the dependability or for the reliability. So it is concerned that if you just cross check this log or this audit during the data analysis, it helps you in in reporting, and if somebody else wants to see it, because then he can also take help. So basically it ensures, because that audit it helps in meta analysis. They ask for it basically because they want to see whether you have throughout the process Prisma, in the Prisma guideline also, they Prisma, I think that's a Prisma is a preferred reporting for meta systematic review and meta analysis. So there it is mandatory to maintain this. But here, since many time reviewer and many time the journal which who publishes this qualitative research, they have not asked for it. That's why we have not maintained, frankly speaking. But you should do that. So it is a systematic record of all researcher decisions, procedure, and changes during the study. And we'll just show this is just a simulated audit trail. So like if you are doing this research on doctor-patient communication, then you can see here that stage one will be like research design and planning. So maybe you have started this on Jan 5, 2024, finalized research question and objective, and then ethical approval was obtained, and then you have started with your data collection process. So you have developed interview guide, you have finalized 12 questions, and then you have done your pilot review. So this was all like whatever activity you are doing on an everyday basis, you keep on noting it down. And then, but this is just a simulated one. This actually we have not done. Like similar code. In coding, yes, many times when we are doing the data analysis and coding, that we write somewhere. What was the decision if we have merged the codes? Because many times they ask for the code books. So in that case, if you have maintained this, so yes, I can recall now that for this thing. Swasth Mitra, we maintain the log of data analysis, but the initial part we did not. And if you see this, this here in the article. Here again, I'll show you. We have how we have like as a part of this research. These are again a little bit thick description. So if you have to see like conduct the interview. I'm repeating it many times because I know that if you don't do your interview well, you will not get thick description, and then it's very difficult. So limitations, like we have accepted the limitations. We have accepted that there is a potential bias because AIMS Patna, because we only train them. So, and we are evaluating. So, this dual role may have influenced the objectivity of assessment and interpretation of the program effectiveness. So, even if like there is some sort of bias, you should accept that bias. Second finding, because again we have written that it has limited generalizability, because in Bihar it is a very context specific. Seeing the Bihar public health system means applicability to other regions with differing healthcare infrastructure and resource availability. It may be constrained. Third, we have also written like there is a presence of this Hawthorne effect, because if the Swasthya Mitra have gone there temporarily initially, then everybody are now tuned because there is a presence of a third party. So now they are behaving well, and they are there's an improvement in staff behavior. And again, we have also said that additionally the study, because this was not a mixed method study, ideally mixed method study should have been done because the study primarily relied on qualitative data. And one of the theme which we have said, that is the reduction in the treatment initiation time. So we have written like success rate or reduction in wait time. We need quantitative data. So that we have not used that. So incorporating mixed method approach would be it is needed. So in this trustworthiness of finding also, if you say and if you acknowledge your own biases, whatever biases during the, because it's not possible to tackle all the biases because of many reasons, then at least you can accept that. I think that's a good idea, and that way gradually you will improve also. I think that's it from my side. Let me see chat. So Priyanka is asking, I'm sorry, I am seeing the question now. If I'm taking data from different stakeholder, will that be considered as a triangulation? Yes, Priyanka, it will be considered as a triangulation. Different stakeholder means like the position is same or what? Can you elaborate on this?
ASHA workers, healthcare providers, and patients. So I'm trying to get everybody's perspective. So that won't be triangulation, right?
Yes, that will be triangulation, because there is a healthcare worker. There are two types. There is a frontline who's ASHA, and there is a medical officer. That's what you said. And then
Yes, ma'am.
yes, that's a triangulation.
But
Because
ma'am, I'm trying to get different. So it is like not a confirmation of, okay.
no, what you are trying, RQ is different for all these three people.
Yes, yes, ma'am.
Okay, then it is not. On the same research
Right.
question, if you are trying to get the three perspective, then it is triangulation. If
RQ is the same, like the same teleabortion, facilitators and barriers to adoption of teleabortion in rural area of Nagpur. So I'm trying to get everybody's perspective, healthcare provider, what they may perceive as a facilitator and barrier. That will be different from the patient.
maybe, but your questions will be like there will be different interview guide, but definitely that's a triangulation. Because you are
Okay, ma'am.
trying to get the perspective on this same phenomena which you have described.
Right. Yes, ma'am. Yes, ma'am.
It is a triangulation. That's what
Okay.
I
Thank you, ma'am.
see. I have just shown you this one.
Mhm.
We triangulated the data between respondent, people living with HIV/AIDS, caregiver, hospital, patient, this thing, and between the methods. So methods
Mm-hmm.
also, like we did FGD with transgenders. So we used FGD with transgender, and we used in-depth interview for people living with HIV/AIDS or their relatives. So triangulation in methods and triangulation in respondents.
Okay.
Respondent means I took people, I mean the patients, caregivers, and the hospital, and the relatives. And again,
Okay.
these informant also. So this is triangulation. We have at least that's what I was saying. At least you can do triangulation at the level of selecting the participants and stakeholder. That is very easily done. And you
All
should make
right.
that you triangulated, because many times we do, but we don't mention it that we have
Yes.
done this.
Yes.
So
Thank you, ma'am.
my pleasure. Then let me see a chat. Dr. Nitin is writing, summarizing the salient feature of an interview at the, yes, very, very important, Dr. Nitin. If you summarize the whole thing at the end, but many times what I have found out that it takes time. You will have to prepare yourself that you have to summarize. Otherwise, by the end of, let's say, 45 minutes or 40 minutes, many things you also forget. Forget means for summarization, you should remember whatever they have said. A few things you forget also. So if you want to summarize, because you cannot go and listen to the audio again. So keep on writing some important points so that you can summarize at the end. Then is the maximum variation sample is it's a part of triangulation. No, a maximum variation sample is not a part of triangulation. It is basically to have representation of all the people, voices of all the people in your maximum variation means it is inside the triangulation. Let's say if you are taking healthcare professional, you not only take the junior resident, or you take the medical officer in charge also, and you take something people who are from Ayush doctors also. So that is maximum variation. Don't take only simple MO 3 MDs. If you have to take credit 4 medical officers, then take one medical officer in charge, take one person from Ayush, and take one person, one female doctor, and maybe some specialist, something like that. That is maximum variation. If you are taking, like, let's say Asha, like Priyanka is taking, so Asha, what you can take some low, because there's a list of low and high performing Asha. So you can take a very good Asha who's very good in at work, and you can take someone who is very lazy or very influential, because in Bihar we typically see that if the Asha is belonging to from a high socioeconomic status, she doesn't do any work. So you have to take both type of Asha, the one who is working very hard and probably one who is only saying but not working. So then you may have the perspective. So maximum variation is maximum variation within one type of respondent. Is it clear, Dr. Arun? I don't know whether he's listening or not. Let me see. Okay, Arun, Dr. Arun. Yes, I will. I'll share this. All these studies. Dr. Ravi, you are asking to share which study?
Ma'am,
Uh,
the current one.
the Jivika Swasthya Mitra.
Yeah.
Okay, okay.
And
I'm
ma'am, whatever good you find to share, sir, it can be a good read, ma'am.
okay. I'll share whatever work. You can see the quality also. Initially, few are very, I mean, not bad, like, but you can understand that.
No, ma'am, we would like to see something which is good, ma'am, first.
No, you should see both. Why?
Yeah,
Because
but
then you know that.
yeah, then you can appreciate the difference between the two.
Yes, because it's
And then do and tell what not to do. Agreed.
no, not
Agreed.
what to do. I will not say what not to do. Whenever you start, you make mistakes. That's very natural for all of us. Uh, I should not say you don't do, because if you don't do mistake, you will not learn. We are None of us are perfect. So like it's the way we learn. And then next is Dr. Arun is asking, familiarity with population can sometimes change our opinion and attitude. Uh, yes, that we have discussed, but you want to say this in which context, Dr. Arun? In reflexivity, you have to write your like there was no prior relationship with the participant. But familiarity means like which type of familiarity? That participant observation. Let me see. In context of reflexivity. Yes, familiarity means here, if you are doing the observation, yes, by the end of 10 or 14 days, you will be familiar. But again, that bracketing thing should be kept in mind all the time. And then, but does not negative case analysis affect the generalizability of the result? Because it will not affect. That's why I said, no, it is not a generalizability, rather it is the transferability. So, because in every society you have got mix of cases. So if you only take the positives one, then that the perspective of that person, the other person who is not behaving the way other people are behaving. So that's the real situation. That's what I said, that it is indifferent to the quantitative. There we remove the outlier. If there's an outlier and you think that it is affecting the result, you do the analysis both ways, keeping the outlier and not keeping the outlier, and see the difference. But here in qualitative, we always emphasize on the maximum variation sample, some negative case analysis, and this is not always possible. You say that you have tried, because negative case, if you really want to do, it is not always easy. There can be a luck where you will get, there can be a chance where you don't get, but you at least you have tried. And you can do this through snowball sampling or through taking help of some of the stakeholders from the community, if you are doing a community based.
Place it in the results, like negative case analysis. How do we place it? If suppose we're doing thematic analysis for the majority of them have a particular.
So what you can do, you can then perform two, that's what you said, not perform two type of analysis. One, do the narrative of one person and thematic of everyone.
Thank you.
Remember that Kari story, which Dr. Ravi was also saying, that they have studied the phenomenology of everyone, and then Kari, they have narrated the story. So you can do narrative analysis, narrative type of research approach, and rest you can do thematic analysis. So that like you are doing justification to both the groups. Okay. Anything else? Any question? Okay. If not, I think so. Praveena, now we have done today's session. So your attendance is marked.
Madam, I have a question.
Pardon?
Madam, I have a question, ma'am.
Yeah, please.
Ma'am, on Sunday, now this yesterday we had done an interview, ma'am, in the breakout room.
Yes,
So
yes.
that audio now I have transcribed into text.
Yes.
Now, what are we supposed to do further on coming Sunday?
I think Dr. Shamshad in the group, he has shared one link of transcription, free transcription.
Yes, ma'am.
So you can use that, or you can do the transcription. Transcription is like you listen to the audio. If you don't want to use, that's okay, because we all have done the transcription, and you should have experience also of the transcription. So you do the transcription, listen that, and you write it on pen and paper. If you are not comfortable on typing, once
Okay.
you write on pen and paper, either you can share that write up to us. We will get it typed, or
Okay.
converted to the soft copy.
Okay, ma'am. So that what we need to do is that write up we need to post in the WhatsApp group, huh?
Yes.
Okay, ma'am.
And then we'll compile all the transcript, and then we'll share to you people, so that we can practice on QDA on Sunday.
Yes, ma'am. Thank you, ma'am.
Okay, my pleasure. So if we are done, can we end the meeting? Any other question? No. Okay. Thank you. Thank you, everyone. So I'm ending the meeting from my end. So good day to all of you.